My name is Cristian Bergman. I'm the Grand Rounds Director, and this is the second internal medicine Grand Rounds of the 2021-2022 season. Today is Thursday, September 9th. Today's talk is titled the Department of Internal Medicine State of the Department with a focus on education and teaching. I'm joined today by Dr. Sime, Dr. Barrett, and Rebecca Miller. I'm going to start with some brief introductions and then turn it over to Dr. Sime. So Dr. Sime is a physician scientist who received her MD degree at the University of Edinburgh in Scotland. She pursued specialist training in pulmonary medicine before traveling to McMaster University in Ontario, Canada to train in the science of inflammatory and scarring lung disease. She has received numerous awards for mentorship and scientific achievements, published more than 150 manuscripts, and successfully been funded by the NIH along with other foundations. In 2019, she came here to VCU and assumed the position of the chair of the Department of Internal Medicine, and she has a strong interest in supporting the next generation of researchers, educators, and clinicians. Dr. Cristian Barrett is a professor of medicine in the Division of Hem/Onc and Palliative Care here at VCU. He received his undergraduate education at the University of Notre Dame, his medical degree at the University of Louisville, and completed his internal medicine residency and Hem/Onc fellowship at the University of Alabama in Birmingham. He joined the faculty here in 2005 and is the current Associate Chair for Clinical Affairs, the Interim Associate Chair for Education, and the Fellowship Director for Hem/Onc. Lastly, Dr. Rebecca Miller is an associate professor in the Division of Hospital Medicine here at VCU. She received her undergraduate degree at the College of William & Mary, her medical degree at Eastern Virginia Medical School, and completed her internal medicine residency with a chief year here at VCU. She became program director of the internal medicine residency program in 2020. And since starting as an associate program director in 2016, she has developed a formal curriculum in resilience and wellness, started a residency program wellness committee, and runs a curriculum in reflective practice for interns. Her scholarly interests are in medical education, including procedural competency, wellness, reflective practice, knowledge acquisition, and assessment. Outside of work, Dr. Miller enjoys spending time with her husband, 2 dogs, completing projects on their historic home in Churchill, paddleboarding and canoeing on the James River, and spending time with extended family. Dr. Sime, Dr. Barrett, and Dr. Miller, thank you all for joining us today. I'm going to turn it over to Dr. Sime to give opening remarks. Thank you.
Thanks, Dr. Bergman, and thanks everyone for joining today. This is the first of our grand rounds of the academic year, so a big welcome to everyone that's new, and an even bigger welcome to those that have been serving on the front lines for a long time. We are, of course, in the midst of another surge, and it doesn't go beyond our notice how busy and exhausted people are, but you're continuing to deliver great care, so I really thank you for that. I've been here for 2 years, and each year we've done a state of the department. It became obvious to me last year that we have so many terrific things going on in our department that we really need to give a lot more time to showcase what we're doing in education, research, and clinical work. So given, I think, the real importance of our education missions to this department, I'm absolutely thrilled that we're kicking off with our educational missions today, and delighted that Dr. Miller and Dr. Barrett are going to help showcase some of the things that we're doing and things where we can improve. And we definitely value your input into all of this. This is a showcase, but a showcase where we really enjoy your feedback either today or in other forums. So thanks for your attention, and we're excited to present where we're at with our research missions.
Can't hear you very well, Cristian.
Are you advancing the slides?
Yes, just making sure.
So today our learning objectives are to basically discuss with you the use of the milestones in medication and medical education as a means of assessing competency and advancement, and to recognize teaching initiatives and skills that create an environment of inquiry. And finally, to recognize the role of self-care and wellness, creating a positive learning environment. So to start, I thought we would introduce some changes. As many of you may or may not be aware, Dr. Call who had been the program director from 2004 through 2020, and then remained as an associate chair of education to complete a transition period, has left VCU and is transitioning to her new job in Asheville, North Carolina. She really was foundational for most of the people that are in the educational office by coordinating and centralizing the procedures and mentoring almost all of us that remain in education here today. And was a distinguished teacher with many awards, as you can see. Next slide. She is currently starting a new program in Asheville, North Carolina, and she has 15 interns, no upper levels. So kudos to her for taking on that challenge as they started a brand new program focused on creating the next generation of people interested in rural health for Appalachia and beyond. She is currently the program director as well as the chair of medicine, and is also a professor at UNC Chapel Hill within their Department of Medicine, where she collaborates as well. To introduce the staff so that you understand who makes up the Educational Affairs Office, we consist of undergraduate education, headed currently by Phoebe Ashley and Adam, along with the assistance of Thomas Bryan, who assists with M3 clerkships, and then Gilda Harris, who works with the acting internships. The residency program core is based out of the office as well, headed by Becky Miller and her myriad associate program directors, as you can see here, who each provide valuable talents, skills with their own specialized area. Rounding out the residency part are the 3 residency coordinators, Catherine Good, Allison Nowitzki, and our newest addition, Henry Lewis III, and the chief of residence. Although not located over in the office, we have our combined programs, including MedPeds and EMI. And then finally, we assist in overseeing the fellowship programs as well. And we have 3 wonderful coordinators there as well. Stuart, who, as you can see, handles geriatrics, HEMONC, palliative care division, and the pulmonary critical care division fellowships. Cecily Watkins, who helps with endocrinology, rheumatology, immunology, infectious disease, and the GI fellowships. And then Jeanette Dawkins-Woods, who coordinates cardiology fellowships and nephrology fellowships. And finally, we have sort of the overarching staff who makes up sort of the procedural aspects, the office manager, the administrative assistants, and records and verifications for all learners, past and present, are handled by Patricia, Ashley, and Monica, respectively. And then Cristian, our newest addition to the team, coordinating grand rounds, as you will figured out by now on our second week. So we thought we would start talking about assessment and feedback, and where the milestones are moving as we move into the second generation of the milestone project from the CGME. So if we look at our own survey, one thing is clear. Our learners indicate that they feel that you are giving them the appropriate level and amount of supervision. They really appreciate your interest in their education and the attention that you give to supervising them. And they do feel as a whole that the amount and quality of the teaching is appropriate and feel comfortable asking and calling you with questions on the clinical services. But they do make clear too that they want a lot more feedback on how they are doing along the way, both during the rotation as well as after the rotation. And the question then that could be raised is, how do we translate all those wonderful observations that we're making into meaningful feedback for the learners? So to start, it's important to understand that learning and growth is a continuum. It's not as if you immediately become a master or skillful. And most of us are familiar with some of these simpler sort of versions of growth and learning. We've all seen the kid playing soccer where their main goal is just to know you run to the other side of the field and try to shoot it anywhere in the direction of that goal. And then with time, they learn to develop better sense of footwork, control, be able to look up without looking down at their feet and all, and to start to develop some sense that they can evade and have strategy. And then finally, in the later stages, a more nuanced skill set in terms of the footwork, speed, agility, evasion, but more importantly, a sense of overview of how the team is functioning as a whole and how they can set themselves up and the players up to work for the benefit of the team. The ACGME Milestones project is essentially that same concept. We would never expect a child to learn how to play soccer, diving, or any other sport and immediately be able to go in there and just say, you know, here's what you do, do it. No, we're very patient in coaching them through that. And we would, at the same time, not think anything of the fact that we're giving them very positive encouragement, even though they were doing some things tremendously wrong along the way. And really feel like we're going to give them appropriate guidance to keep them encouraged and motivated to keep learning the skills. Well, in many ways, the ACGME company milestones were recognizing the fact that, yes, that is true, but grades and passing in 3 years is a meaningless way of simply encouraging someone forward. Instead, the milestones said, what are we trying to produce? Competent, excellent positions. And then went backwards and said, well, what are the skills and attitudes and attributes that are needed for us to achieve this outcome? And those became the core competencies: patient care, medical knowledge, etc. And from there, it was a recognition that, well, patient care consists of many things. And so they broke that into components: history taking, physical examination, and interpretation, which essentially became the sub-competency. And then ultimately, relevant to what you all do on the floor and when you're all providing feedback, were the milestones. It was taking each of those individual sub-competencies and breaking them into developmental steps that could be observed. Were they doing this or not? It was no longer a conceptual stance that you need to be able to take care of patients, or even a little bit more nuanced, you need to take a history. It was much more of a, are they able to take general questions and just throw a blanket net over the history taking? Are they able to focus and target something specific to the presenting complaint? And ultimately, are they able to make and look for informative subtleties that might inform the underlying genetics or the family trends that go under those diseases? And so each of those are observable developmental steps, and you're not going to expect someone on day one to jump right to the end. You cannot master the third until you have mastered the first and the second steps.
And so, as Dr. Barrett so nicely described, the ACGME milestones are competency-based developmental outcomes. So this is one framework for assessing competency and allowing for appropriate advancement in the context of medical education. And it includes a set of knowledge, skills, and attitudes that learners may demonstrate at the beginning of their education, throughout their training, what they should demonstrate at the time of graduation, and ultimately behaviors we like to see in unsupervised practice for the rest of our careers. The milestones were developed about 10 years ago and implemented maybe about 8 years ago. And I remember because I was a resident at the time, and Dr. Barrett was my advisor who gave went through my first end of year review based on how I was doing on the new ACGME milestones. So I'll never forget that. With that, the initial milestones that were developed, milestones 1.0, we found could use a little bit of improvement. So we've been assessing learners using these milestones for a while now. What we have found is that the original milestones had some somewhat opaque concepts that included a lot of medical education speak and not a lot of clear observable behaviors. They're very complex, and individual milestones would tie together many behaviors and concepts, often included negatively worded descriptions, which implies that performance is below expected level when that may not be true. So if someone is not doing something, it may be appropriate for an early learner to not yet be able to do a certain behavior in patient care. But when given that feedback, it feels like you're not meeting expectations. And there's a lot of variation among subspecialties, making it challenging to really follow along that continuum of development if you're thinking about developing from a resident to a subspecialist in training and then in unsupervised practice. So this year, the second set of milestones were put into action. So they've been in development for several years now. And this year is the first year we'll assess learners on using Milestones 2.0, which have incorporated more of a growth mindset. The phrase critical deficiencies has been replaced with not yet completed level 1, because someone may not yet be demonstrating certain behaviors doesn't necessarily mean that they're critically deficient. It just means they're not yet there. Descriptions have been changed from negative to positive wording. So they no longer describe what a learner is not doing, but they very clearly describe what a learner is doing or can do consistently. We've taken away the anchors of critically deficient to aspirational and replaced it with a numeric scale. Level 1 is appropriate for an early learner most of the time, and level 5 is really a role model, a coach, or a teacher. So learners may not even reach a level 5 by the time they are at the time of graduation. That's really in the unsupervised practice timeframe. And they're also less complex, separated into more individual behaviors and concepts. And just as an example of how we're using the new milestones differently in our new evaluations, we have completely rewritten most of our evaluations so that when the questions on evaluation forms are line items from different subcompetencies. So you're actually assessing a learner on their level, and the level 1 through 5 doesn't change throughout training. So, and you can also rate someone as not yet completed a level 1 or not yet observed. I'd like to thank Dr. Paletta-Hobbs and Allison Dubinsky and our core program for putting a lot of work into developing these new evaluations. But really important to point out that this changes how you might assess a learner or be assessed as a learner, where you may be performing very well as a new intern, and you may be meeting all of the expectations of your supervisors and teachers or even exceeding them. But unlike our usual Likert scales, where 5 indicates doing as well as you possibly can, couldn't do any better, at this point it means a level 5 means you're ready for unsupervised practice. So an early learner really shouldn't be a level 5, and it's appropriate to be a level 1 or a 2. Level 3 would be fairly exceptional. So it takes a lot of reorienting both for evaluators and those being evaluated. And I'm really grateful to Dr. Paletta-Hobbs, who spent a lot of time working with faculty and is willing to come meet with any faculty in any division if you would like to do some training in how to use these new evaluations.
Some complementary frameworks that we're familiar here with at VCU include models such as the learner manager teacher framework. And this was developed by Stephanie along with its conceptual creator, Kevin Hinchy, actually prior to the onset or the development of the milestones themselves. But it was a recognition, and remains a recognition, that even as you get to the end of 12 months of internship, and you may well have acquired a substantial amount of the prerequisite knowledge and skills, that at that point you may be ready to move on and let the training wheels come off a little bit, but maybe not good enough yet or secure enough in your knowledge and your skills to be supervising and teaching junior learners. To do that, if you want to do justice to the younger learners, you really want to make sure that they're competent truly to do the management on their own. And so this model then said, like, before they get the way I grew up when I was an intern and resident, on June 30th, you were there, you were supervising the interns the next day. Here it's separated out, say no. Before we do that, let's supervise them and assess them a little bit more intensely while they manage it without someone sitting over their shoulder the way they used to with the residency. And then, only then, once they be deemed competent by the hospital medicine who really oversee much of these teams, then they're deemed capable of moving on to a teaching service where they have junior learners under them. These same concepts have been applied certainly here within the medical student realm as well. And many of us are familiar too with the RHIME formulation. Reporter, the interpreter, and manager, a well-validated tool developed back in the 1990s as well. And it supplements the traditional honors, have, pass, and fail by really explaining, similar to the milestones and the teacher manager models, exactly what are the skill sets that that person is capable of doing. And so no longer is it just an assessment based on time or grade, gestalt. It's actually observable behaviors. Are they doing these things? Which sets us up really for the question, which has ultimately been due, of is time the ultimate arbiter of how we advance students within the medical profession? Or is competency really what we're trying to shoot for? So traditionally, 4 years of medical school, 3 years of internal medicine residency, and then perhaps 1 to 5 years of subspecialty training if you chose. But everything was time-based. It had nothing to do with your individual skills. It did nothing to recognize that all of us are progressing along these competencies and milestones at different paces. And so we certainly would never have kept Mozart back from being able to be a concert pianist. We would have done him a disservice to say, no, you have to wait till you're 18. So why are we doing that in medical education? And so that is also in the process of changing.
Through this process of changing, there are many competency-based graduate programs in medical schools, and we're fortunate at VCU School of Medicine to have recently developed a competency-based graduation program. And this is a program that is offered, or similar programs are offered by about 15% of US medical schools, which is more than Dr. Barrett and I both thought. We thought we were very, very unique, but we're excited to be a part of this program in internal medicine, one of the specialties that works with the medical schools in fostering the students graduating early if they're ready based on their competencies. So this program allows students to graduate in 3 instead of 4 years of school. They apply at the start of their M2 year, and they undergo a rigorous, very regular assessment of competency, looking at their grades, their performance in the clinical arena. During the M3 year, their M3 elective is replaced with an acting internship in the specialty of interest. They actually apply as an M2 into a specialty, and internal medicine, family medicine, emergency medicine, OBGYN, and psychiatry are the standard programs that are currently offered, although they can elect in or inquire about applying to another program earlier. We haven't done that yet, though. And they get increased specialty mentorship from their preceptors and the program directors during this time. And ultimately, by the middle of their M3 year, when it's time for us to make our rank list, they have applied formally and interviewed, and if appropriately, will be ranked by the residency programs and essentially guaranteed to match into our program. We're really fortunate to have recruited 3 amazing graduates of the competency-based graduate program in the first 2 years that are current residents in our program. And this is also a fantastic way for us to keep our exceptional VCU students here in our residency program, which we always love to do. So this is really exciting and something that has been developing over the last couple of years. I want to give a shout out to Sarah Hobgood, who's been the director of this program, is currently transitioning and working with Nina Vito, and who's an emergency medicine, internal medicine graduate. But Dr. Hobgood, along with Dr. Santon, has done a lot of work to get this program off the ground. All right, so moving into our next session, we've talked about assessment and feedback, knowing that this is a really important part of learners' growth. So we've talked about different ways to assess learners and using competency-based frameworks, which are really behavioral based and set you up really well for delivering great feedback. Another very important part of education is the learning climate. And so we're going to talk through a few components of the learning climate, sort of where we are and where we want to be, and ways to get to our goals and in the context of a learning climate. So to start off, we are going to use the Stanford Clinical Teaching Framework definition of learning climate, just to give you an idea of how we set our goals for the learning climate in the Department of Medicine. So those of you that can, in the chat, send to me, what are your thoughts? What are components of an effective learning climate? "30 seconds so we don't go too late." Great, so open to all questions, so openness. Psychological safety, fear. So fear from humiliation or not intimidating, or things. Wow, we're getting lots of responses. Thank you. Free of distraction. Thanks, Dr. Wickham. Mutual respect between students and attending, using names, making people feel comfortable, ability to ask questions, receive answers, not being afraid to ask questions. Trust. I love it. Awesome. Thank you for these great answers. Oops. So these are the 4 components that the Stanford program defines and sets teaching behaviors within each component. So stimulation, learner involvement, respect and comfort, and admission of limitations. So you hit most of these in your responses. Thank you, everyone. A part of the learning climate and one of the common program requirements according to the ACGME and the section about the learning and working environment is that residency education must occur in the context of a learning and working environment that emphasizes the joy of curiosity, problem solving, intellectual rigor, and discovery. And to do this effectively, to allow for curiosity, problem solving, and discovery, you must have the right learning environment, the right learning climate. So that openness to questions. Why is this a challenge? Well, there is this concept of inquiry-based learning, but most of us don't train in an inquiry-based learning environment. Many of us have trained in traditional education, which actually often, if not overtly, does discourage inquiry and limits curiosity because it's focused on assessment. It focuses on getting the right answer. So learners are told what question to learn the answer to rather than thinking about what questions they have. And ultimately, learners in a traditional model may be less prepared to enter practice that emphasizes creativity and problem solving. Like medicine, we solve problems, solve problems, and try to solve them every single day. So to give you some thoughts about structures and supports that for inquiry-based learning, whether you're a learner or a teacher, many of us are both. So important to engage in your own development in inquiry-based learning. So we'll do just a few minutes of that here in the next couple of slides. As a teacher, you have to create a community that fosters inquiry. So asking for questions, asking differing opinions, allowing people to speak up and have an idea that's different than your own or different than the idea that maybe you think is the right answer. To engage in inquiry daily. This is not something that occurs every once in a while. It occurs in all of the teaching that you're doing. As questions are being developed, it's not about what's the answer and why is it right, but why is it important? What does this relate to in the work that we do? And then considering what's the purpose of the question. Why is the question that you're asking, the inquiry that you have, even important? Again, it's getting away from the answer and more about the question, the relevance, the connection to what's out there. So how can you engage in inquiry-based teaching or learning? As questions are being asked, or as you're asking questions, move them up higher on Bloom's taxonomy. So focusing less on what is the answer, can you tell me if you can you describe this to me, but really asking for that application, analysis, evaluation, and creation of ideas and concepts. it's really important to ask why. Embrace those open-ended questions where there might not be a right answer. I keep saying that, and be okay with not knowing. So you might ask a question that you don't know the answer to as a teacher. As a student, there may not be a right answer. The person in the teaching role may not know the answer. But as a teacher, you can really push the questions further by using sort of that perspective of time and setting. So maybe there's a question with the right answer about how did we treat this patient with, acute decompensated heart failure? Well, maybe the question would be, what if we didn't have that medication? Or how did we even get to developing this medication for the treatment of heart failure? Why do we have this? What if our patient had this other medical condition? How would your answer to this question change? Role model, looking for answers and using EBM to guide questions. So these are things that you can do to really foster that environment of inquiry and inquiry-based learning. We have Dr. Barrett will talk to you about some of the curricula we have in the Department of Internal Medicine to really foster this.
Yeah, so Becky's point about why is really at the heart of the physiology retreat. And these are two examples of things that we do here at VCU to try to engage the learners at the residency program level into sort of a love for the role of inquiring, the love of the role of teaching, because after all, that's what motivates most of us to go to work and keep doing what we're doing. A love for the science and a love for the patient care and a love for teaching and interacting with the learners. And so in the PGY 1, beginning of PGY 2 comparative physiology retreat each year, the whole premise is ask why. And we break out into modules and have them work within sort of groups, asking basic questions related to hematology, cardiology, pulmonary, endocrinology, nephrology is there. And really have fun going back to some basic science experiments, not so much focused on the complexity of the experiment, but again, why and how does this apply to what we see at the bedside, so that they can, in a sense, role model for themselves being at the bedside and thinking beyond just simply, I'm given the Lasix, but thinking, what is the Lasix actually doing? And they play that out within their scenarios by seeing the effects of volume overload and salt loading in their own physiology. In addition, the PGY 2 teaching retreat goes from the teaching standpoint and really puts them into scenarios where they're acting out and role playing and really critically thinking, what's creating a good learning environment as I transition from that learner posture towards being a teacher? What skills am I going to need to perfect and to hone my skills of supervision and giving feedback, and they too creating a learning environment that is a positive one in which to learn. And so again, developing a framework by which they can develop themselves. And during the Stanford model, which is the backbone of the teacher retreat, for those of you who've gone through it, you'll be familiar with this. Each of the learners are asked to develop a goal for themselves personally, as well as a goal within that teaching technique, creating learning environment, feedback, assessment, to develop an institutional goal. And shown here are an aggregate of some of the most common institutional goals that they've outlined for themselves this last year. And technically, I suppose that institutional goal they've outlined for you as their teachers. And so you can see exactly what we've already discussed. What they want is they want to know what you're expecting of them at the beginning of the rotation. They want to set out expectations that you have for them. And conversely, it's worth asking them, what are your expectations of me for this rotation? And what are you trying to get out of the next 2 weeks? And then feedback, above and beyond feedback. You can see 3 boxes under this column, because that's how much importance they put on feedback. They want it regularly, not just at the end in a written evaluation, but they want to hear from you so they can get that sort of clarifying specific things that they can do to improve their skills towards being a competent physician. And they want it to be constructive feedback on the evaluations that, again, are actionable items for them, something they can concretely work on as much as possible. And in addition, you can see there, they want examples of non-directive learning, as Becky has outlined. And they want to assign literature and following up with the discussion. So not just saying, look at it, but having a conversation that allows them to bring that back and tell what they've learned and have that further conversation with you. And to acknowledge your limitations and to help mitigate interruptions to the learning environment.
One thing to highlight from this that came up a lot in the chat, someone mentioned acknowledging limitations as a part of an effective learning climate, which is absolutely true. But one thing too that can be helpful is acknowledging limits in medical education. And one of my favorite examples from this discussion was when a resident said, maybe we're running late on rounds because we had a critically ill patient that we had to spend a lot of time with. So unfortunately, I had to, maybe interrupt the medical student that's presenting a little bit more. But rather than just interrupting to kind of speed along the presentation, you could say, I'm sorry that I'm not going to be able to allow you to fully present the patient today because of everything that's going on, not because you're not doing a great job, but we just so that we can focus on this urgent patient care issue, we just need to move a little bit faster. So acknowledging that sometimes there are limits in medical education and we can't always engage in best practices. And Alan Dow set me up for this really well. And his comment in the chat, the last one that came through about an effective learning climate, was joy and care and joy in learning. This slide depicts to you some themes that were identified by residents and fellows as a part of a council of residents in the ACGME. And the sort of 6 themes of what brings them joy and meaning and work. And all of these have to do with learning climate, including a supportive collegial learning environment, progressive autonomy that gets back to our competency-based advancement, reduced time spent on non-clinical administrative responsibilities, a sense of teamwork, and then highlighted here, more time spent at the bedside with patients, which I think that most of us can relate to. So this is not just for residents and fellows, but for all of us, getting to spend more time at the bedside. So how can we bring that into creating a more effective learning environment? Well, one thing that we really like to emphasize in the residency program for residents, fellows, and students is bedside teaching. So not just the residency program, but the entire department. So if you follow this person on Twitter, they actually have a whole long thread about the best articles that share practices in bedside teaching. And one of them I've highlighted here includes 12 tips to improve bedside teaching. It's actually from 2003, but I think it's still very relevant. So how can you be effective in teaching at the bedside, foster a great learning environment, still take great care of patients, do this in a timely fashion. So I encourage you to read this. I won't read from the slide, but this is a great resource, but it involves a lot of preparation, being really intentional with how you're running rounds, and then debriefing, getting feedback, reflecting, and preparing for your next session. We have some faculty champions in this area that I like to highlight. Of course, Michelle Brooks, who has taught me almost everything I need to know about bedside rounding and really been a coach for me when I've struggled with teaching at the bedside. The hospital medicine education team as a group has been champions of this and really trying to foster bedside teaching. So that teaching, presenting patients at the bedside in the room with the patients. Over at the VA, Derek Leiner has been acknowledged as doing this really well as Samir Bakhari. And then in clinic, so outside of the wards, Dr. Aaron Fox has been noted to be an exceptional bedside teacher. So I just wanted to give them some credit and people you can go to for help in this area if you want to work on your bedside teaching skills. We are in the process in the residency program of really formalizing a comprehensive advanced bedside skills curriculum. We've had a big focus on bedside rounds, patient-centered rounds for the last, 5 or 6 or more years, really. And this year, we're going to focus a little bit on physical diagnosis, and over the next couple of years, implement, roll out curricula and sort of advanced communication skills and point-of-care ultrasound. And as I said, this year, the emphasis will be on physical exam. We have another epic rollout of our Enhancing Physical Exam curriculum, which is a 12-part lecture series, including videos, that is intended to foster a culture of teaching physical exam skills to learners that will be taught during our faculty ward orientation, but all of the resources will be available in our general medicine teaching app, and we'll share that with you at the end of this section. I'd like to highlight these faculty and our chief resident who've really helped put this together, and it's really just brushing the surface of what we'd like to do in teaching physical exam skills. To tie all of this together, how can you teach really well at the bedside? If you think that you want to brush up on these skills, we encourage you to go to our app that you can learn how to access this on the New Innovations homepage. There's tips for rounding, bedside rounds, things like that, many teaching tools. And a shout out to one of our fellows and former chief residents, Jared Dyer, for putting this together, as well as current and past chiefs who've kept it running. When we're thinking about the learning and working environment, it's not just about inquiry and teaching effectively at the bedside, but we also have to think about the specific behaviors that we want to avoid. This is really important in medical education for all of our learners. So the AMA report to the Council on Medical Education has defined mistreatment as either intentional or unintentional, and it occurs when behavior shows disrespect for the dignity of others and unreasonably interferes with the learning process. The ACGME Common Program requirements outline some specific requirements for residency and fellowship training programs, in that they must provide a professional, equitable, respectful, and civil environment that is free from discrimination, sexual and other forms of harassment, mistreatment, abuse, or coercion of students, residents, faculty, or staff. And this is very important to having an effective learning environment. So you might ask, how do we do this? How do we even start to address these problems if they exist in our environment? So I have learned a lot from Dr. Reshma Jagsi, who was actually at our institution last year. In addition to being known clinically for her work as a clinician and a researcher, she's also the residency program director at University of Michigan in radiation oncology, and has done a tremendous amount of work in bioethics and gender equity. And when she was visiting, one thing that she mentioned that she does with her residency program is share data about incidences of mistreatment and harassment, and sort of what is being done to address that globally to really foster transparency. So that's what we'll do today. On our annual program survey last year in the internal medicine residency program, we asked questions about mistreatment and harassment that are identical to questions asked by the AAMC to medical students, and we'll share some data there as well. So there are a lot of questions. Anything that is in yellow are the responses that respondents indicated that say this, that it never happened to them. So if you look at embarrassment and humiliation, close to 70% of residents have not been embarrassed, but over 30% have. About 15% say that they have at least once been humiliated, and a very tiny percent said that they had been threatened physically, while everyone else for these other items that they never reported being harmed physically, being subject to unwanted sexual advances, or asked to exchange sexual favors for other performance evaluations or opportunities. The second set of questions asked about being denied opportunities, being subject to offensive remarks, or receiving a lower evaluation for certain reasons. And in these three categories, which I meant to label: gender, race and ethnicity, and sexual orientation. So you can see that over the majority of individuals say that these things have never happened, but some residents report that this has happened occasionally. And when asked who directed this behavior towards you, you can see it's been a mix of different individuals in the environment. One group that we did not ask about that I think is important are patients, but that was not an answer choice. And the majority, over 75%, did not report. And the reasons most commonly were that the incident didn't seem significant, or there was fear of reprisal. There is survey data from all graduating medical students in the class of 2021. So this is not specific to internal medicine experiences, but the same question. So you can see the majority of respondents answered had they never experienced any of these situations, although public humiliation did occur more regularly. They did not ask about embarrassment, I guess, because those two are very similar. And then in these concepts of being denied opportunity, being subjected to offensive remarks, or receiving low evaluations based on gender, race, or ethnicity, or sexual orientation, the vast majority say they never experienced this, but there is some occurrence of this. And tied to this is the evaluation of the clerkship in this questionnaire. And you can see performance data here, asked specifically about educational experiences. Yellow implies that the responses are in the 50 to 75th percentile of the third quartile, orange, in the second quartile, orange in the third quartile, and red in the lower quartile. So overall, educational experience in the lower quartile may or may not be related to the learning environment, but this data was sort of asked and presented together. You'll see that 87% of students did say they had a good or excellent experience, but that's not as great as other internal medicine programs in the country. One thing that gets in the way, I think, as we noticed when we asked our residents, of being able to effectively manage mistreatment and harassment and how it contributes to the learning environment, is this opportunity to raise concern, especially without fear of reprisal, and having a good process for dealing with this. On the ACGME survey, particularly for the residency program, and I think this showed up in the fellowship programs as well too, this is an area that we have to work on. So being able to allow learners to raise concerns without fear and increasing their satisfaction with the process. So we've done a lot to enhance this, but just wanted to highlight a couple of ways that learners can raise concerns. So through an anonymous reporting mechanism, this is on the homepage of New Innovation. So there's an anonymous survey that's reviewed once a week by me, where learners can submit their concerns. The same exists for fellowship programs. This is actually new as of this week. And then if learners want to report outside of their program, they can also report to the at the GME level, and then Dr. Aboff will manage that concern, sometimes bringing it to the residency program. So, and then there are other ways to report concerns that we have posted in a document that outlines the processes if you wanted to go outside of the educational programs, how to report to HR, either at the VA or at our own site. So this is a big part of how we manage this in the learning environment, is if we know about it, then we can do something about it.
I would add to that certainly those surveys are not restricted to completion by house staff. The fellowship survey was purposely designed so that you have the option of identifying your role within the institution, but you do not have to. But certainly could be completed by anyone: nursing staff, administrative staff, clinical staff, faculty, residents, students, fellows, and the like. So if you have something that you're just not comfortable reporting directly to the program director or to the department leadership, certainly take advantage of these anonymous methods. Or if you just feel uncomfortable directly approaching it, but still want someone to follow up with you, there's the option of including your name for follow-up purposes too, so that we can discreetly contact you if you've indicated such. But all of that goes back to another question of self-care and the work and health environment of our staff and our learners. Because certainly harassment, frustrations, belittling can sometimes stem from underlying burnout and stress on ourselves. The good news is, from the ACGME surveys, the internal surveys, is that the vast majority of us, both learners and faculty alike, love what we do and we find it meaningful. The work environment, we say, is supportive here within the department, and that our work we find to be a positive challenge with lots of opportunities to find new and interesting things that keep us engaged. However, if you look at the survey, there are some areas of interest that we do want to also transparently share with you. So these are termed in the disagree and strongly disagree. So it's on the opposite side of the spectrum. But if you look here, you're going to find a trend. The fellowship learners are amongst the most adjusted and happy of the group. So they certainly perform better in many regards than the residents and the faculty. But you can see here, a full almost 18% of the residents feel that they have an unreasonable amount of work to complete in a day. 22% feel that they're not necessarily engaged in their work, and 34% don't feel like they have enough time to reflect. Similarly, if you look at the faculty, 14% of the faculty feel that they just are so busy here that they just don't have time to think during the day. And that can range from 0 to 25%, depending upon the subspecialty program that was being reported. But more impressive is when you get to the, how are you doing in terms of your emotional state? Emotionally drained. Does it take you more time to relax when you get home? And do you feel just absolutely worn and weary after work? And you can see it, a huge number of the individuals who complete these surveys, which is not an insignificant number of us, are reporting that we are just drained at work. Over half of the residents, a third of the faculty, and a quarter of the fellows. In terms of feeling worn out after work, almost 3/4 of the residents, and again, a third of the fellows and the faculty, and half or more essentially find it taking more and more time to relax when they get home. Now, while these are certainly true across the country, the numbers are abysmal when you're looking at the institutional and national standards on these ACGME surveys. I would be remiss to say that VCU is doing just average. This is unfortunately one area where we are doing better, so to speak, or worse, as it really stands, than the average. Our faculty, particularly, report at a substantially higher rate of feeling emotionally drained and worn than the national standards for most of our programs.
So there are, a number of things, particularly, and I can speak to the residency program, but I think it applies, a lot of the work that we're doing applies across education in the department to address this. And one of our program priorities, as I've shared with many faculty this year, is to really look at areas of high work intensity and see how we can seek to optimize that. Something else is also just being in touch with how learners are doing and what they need, and giving them a way to essentially raise concerns about how they're doing from a well-being standpoint. So I've had the opportunity to work with some really awesome people on creating this app that's made in Microsoft Power Apps, including Dr. Call, our program coordinators, Catherine Good and Henry Lewis, and Neha Gupta, one of our residents, which allows, it's currently accessible to residents, and we're looking how to make it accessible to more individuals in the health system. But it fosters this opportunity to do a self-check. How am I doing? Connect with resources, and also allow for escalation and asking for help if someone is not doing well. So this is an example of what that self-check looks like in these different areas. How are you doing? And the responses go from that green to red. And once you get to the orange zone, the idea is that maybe we should really pause and something needs to be done in this moment. They are prompted, given ways to get in touch with people that they could reach out with in that moment, and also connected with resources. So if they're feeling particularly physically exhausted, here are some things to get some more rest. Maybe it's that you need to actually go home and get some more rest. So that's when you should reach out and ask for help. So this is just one thing that we have done in the residency program, and are looking forward to sharing beyond the residency program to help address this area.
So I think we don't have full solutions for this problem of physician burnout. It's certainly a recognized national problem, but it's going to take a lot of effort on all of our part, because promoting our own self-care is promoting a healthy learning environment. We cannot give what we do not have. And so the rate of burnout for us as an institution certainly poses many threats to our patient safety, threats to the learning environment, threats to ourselves. But it also poses some opportunities for us to develop new programs, new education, new awareness, and to really help foster an environment where it is okay to acknowledge our own limitations and to seek the help that we need. So I really encourage everyone to let us know if you have sort of educational needs around these topics. Let us in the OEA understand what it is you'd like to hear more about. We can certainly look for faculty development opportunities that we can do in collaboration with other leadership within the Department of Medicine. In addition, for the fellows, we're looking at opportunities to, even despite the fact COVID is still among us, to start doing some face-to-face cross-fellowship interactions. And Trey Wickham and Jason Kidd are spearheading an effort with me to really try to bring across the department a sense of community amongst the fellows, so that we're not all isolated individuals, but recognizing we are part of a great Department of Medicine. We have to just know that there's a lot of opportunities and support for us within.
I think before I turn it back over to Dr. Sime, important to note, these surveys did go out in about March of last year. So right as we were coming out of the height of the pandemic, and knowing sort of how hard our house staff were working during that time is an important, and faculty is an important context to take in that data. All right, I'll turn it over to Dr. Sime.
Thanks. I just want to wrap up and thank everyone for your amazing contributions to the care of our patients. And we so appreciate our learners. It's really one of the main reasons that many of the faculty are here at the institution. And I think you've seen today really kind of what our educational missions are all about. We really are trying to produce compassionate physicians. We're trying to create collegial and supportive environments, and we don't always get this 100% right. You've seen the surveys, but something we strive for every day. We really want to partner with everyone to accept many of the challenges that we see in all of our patients, including the medically underserved and those from underrepresented backgrounds. Next slide. And this is a learning environment. We really want to contribute to the science and the art of medical education itself through innovations and training. And I think your educational leadership here do a terrific job in this role. And I think really not just advisors at VCU, but also nationally. And I'm really proud of their efforts. And we want to partner to advance science. It's really important that we are addressing the unanswered questions of medicine today so we can do better tomorrow. And we're all lifelong learners, myself included. You know, medicine changes rapidly. COVID was a fantastic example of that, where I think faculty, nurses, administrators, everybody stood together with the learners as we all managed to cope with this together and learn from it. And we're continuing to learn today. Next slide. And really, I just want to thank all of the learners and all of the educators on this call. Becky made a great point. Many of us are both. We're both learners and educators. Really thank you. We thank our teams. Next slide. You are our team, and we're really just very proud to be your colleagues. So thanks for all you do for our patients and for each other. And please take care as we battle through another little dose of this pandemic. And we'll have some questions if there are any.
Feel free to, thank you all so much, really appreciate that. Feel free to informally use the chat or the Q&A feature. We have maybe 1 or 2 more minutes. We can unmute anybody who wants to make a comment. And yes, thank you, Thomas. The code for the CME credit is listed in the chat box now. You'll get the notice after as well. If no other comments, we'll thank our panelists today, and thank you all for the second grand round session. Just a plug, next week, we have an external speaker, Dr. Yancey with cardiology from Northwestern Medicine. So look forward to that, and we'll see you guys next Thursday. Thanks for everything, and thanks Dr. Sime, Miller, and Barrett. Appreciate it.